Welcome, good group, and I will be trying to monitor this today as well as present information. So, um, good morning. Hi, Calvin Allen, glad you're here. Okay, so I'll try to go back and forth a bit, but mainly we'll be presenting information. But again, love participation. So first question that I'm going to ask and that I'm going to answer is who am I? My name is Bronwyn McInturff, and I have a master's in social work. I've been in the field of studying and working with addiction recovery for over 20 years. I spent the majority of that time at UAB Hospital in the addiction recovery unit, which had an inpatient and a residential and an outpatient unit, a detox unit. I actually retired from there a few years ago and now work part-time still at UAB, seeing outpatients for individual therapy, mainly working with those who are experiencing or in recovery from a substance use disorder, or those with trauma, a trauma background. And as we know, there's the intersection of both. So I see a lot where there's many issues and those kind of overlap each other. I am not a person in recovery, but a strong ally and have been really since I started experiencing people working on their recovery journey back in grad school. I was touched, I was drawn in, and I've never left. So glad to be doing this today and glad to be partnering. Thank you. Thank you to the APC. I have worked with the APC for over 10 years, volunteering, speaking, serving for a short time on their board. So I'm really happy to represent and be a part of their work as well. So how are we going to start? We're going to start, with a little self-care. Let's see, I'm trying to share a slide and I'll just end my show for a minute. Okay, so we are going to start with just a moment of self-care and bring some self-compassion to our work. Self-compassion is really necessary for what we do. And it's an inroad, I believe, in then being able to bring compassionate care for others. So we're just going to take a few minutes today for ourselves. You can close your eyes during this, or you can keep your eyes open, and there will be something for you to kind of look at. Let's see. Not sure what's happening here. I'm not the best at this, but I think I've got it now. Here we go. Okay, I'm going to share my screen. We're just going to take a few minutes for a compassionate, mindful moment. I'm muted. Thank you. Thank you for taking a few minutes to start this off with just a regulation activity. I think that's so important that we start from a regulated place and that we start from a compassionate place. Compassion is part of what is going to help combat stigma. And when we bring compassion to others, we have to start with ourselves. So thank you. And we're going to go back to the presentation material. And see, here we go. So let's start with a definition. Get on the same page about stigma. What is stigma? So there's a definition from back in 2001 based on kind of a lit review and trying to come up with something that would encapsulate it well by Lincoln Fallon. Prejudice, avoidance, rejection, and discrimination against people who have a socially undesirable trait or engage in culturally marginalized behaviors, such as drug use. Addiction, drug use is such a stigmatized behavior that it is literally in the definition of stigma. I think that's important to take with us today. It is literally the poster child for stigma. Goffman goes on to say it's an attribute that's deeply discrediting and reduces the bearer from a whole, unusual person to a tainted, discounted one. And we'll be talking more about what stigma does later, but that gives you kind of the overview. Reducing people from a person, a whole person, to somebody who's discounted, painted, less than. And as a result of stigma, it says then that there can be discrimination, just to throw out the definition of that. It's the unfair treatment of individuals with the stigmatized condition. Okay. So a couple of definitions to get us started. And now we're just going to do a couple of quick pieces about addiction. They'll speak to stigma as well, but just kind of give a background on it. So this is the definition from the American Society of Addiction Medicine. It changed a couple of years ago, and it changed to, definitions change over time. Part of the reason that it changed, though, was to include that it is a treatable chronic disease just as others are. So it is a treatable chronic medical disease involving complex interactions among brain circuits, genetics, environment, individuals' life experiences. Those are the vulnerabilities. Those are what come together to produce this thing called addiction. People with addiction use substances or engage in behaviors that become compulsive and often continue despite harmful negative consequences. That's highlighted because sometimes it's hard for people to understand, families to understand, practitioners to understand, law enforcement, medical, why, hey, if they're diagnosed with liver disease, why can't they stop drinking? Well, that's part of the other condition that they have. And part of the definition of that is that they continue despite harmful consequences. If people find it pretty easy to stop the behavior when harmful consequences come, then that really doesn't fall into the category of addiction. It's falling into that category when people are experiencing negative consequences, harmful consequences, and having a difficult time stopping the behavior. Not going to get into diagnosis, except to say that that's changed as well. In clinical diagnosis world, let's be honest, part of it is insurance billing world. We use the Diagnostic and Statistical Manual for mental health disorders. And it goes through different versions, every however often. The old version, or the most recent old version, had two categories for addiction: substance abuse. We'll be talking about that word a lot more later. And that was a different thing than substance dependence. Substance abuse was considered more behavioral, maybe somebody could go through that for a period of time and stop using, or maybe, with consequences might stop. And then substance dependence was more what we think about this thing called addiction. And it could or could not have the presence of physical dependence, meaning tolerance, withdrawal. Those two things make up the physical dependence. Lots of people think physical dependence is necessary for a diagnosis. That is not true. But we changed, and we changed some years ago in this new manual that helps us diagnose. And we now have one diagnosis: substance use disorder. It varies on what substance the person is using, but we no longer have abuse versus dependence. We just have a substance use disorder, mild, moderate, or severe. So more of the way that they're looking at other mental health disorders too, instead of carving out sort of different names. For instance, there used to be autism and Asperger's. Now we have an autism spectrum disorder. Well, now instead of substance abuse, substance dependence, we have substance use disorder, mild, moderate, and severe. And I think, and we'll talk about this later, that they also changed the diagnosis. Number one, to reflect the continuum. Number two, because abuse and dependence were very misleading words. And as we'll explore more today, words matter. Language matters. So prevalence, how prevalent is this? When I do these, and I can see people, and I'm in an audience, and I say, hey, raise your hand if you've been touched, somebody close to you, yourself, a good friend, has ever had an experience, with substance use or been in recovery from a substance use disorder. Everybody raises their hand, right? So it's very prevalent. We know this from a sense of it, but when we look statistically, it's huge. It's one of the most common mental health disorders that there are. And of course, it overlaps with other ones, but standalone, it's one of the most common mental health disorders that there is. So over the course of their entire lives, about 29.1% of the US adults have met criteria for alcohol use disorder or another drug use disorder. Doesn't mean that they went through treatment for that, just means at some point they would have met criteria. Most often, the statistic that we look at is kind of current in time. What percentage of the population has an active substance use disorder? This varies. I read different numbers a lot of times in different journals. It goes back and forth, but mainly the estimates that I've seen. And of course, this isn't a perfect science. How are we getting these numbers? They're various, from self-report to looking at people who seek treatment. So it's not a perfect science, but at any point in time, around 8 to 10% of the US population is estimated to have an active substance use disorder. I took this from Recovery Research Institute. They're just a great advocacy center. They have a free website that you can log on to and see all of their data. You can see presentations that they have that are available to the public. Their director, John Kelly, I'll be referencing him a lot in this presentation today. They're just a great advocacy and research organization. So this is one of their banners that they have. More people suffer from an addiction than diabetes, trying to show us that not only among mental health disorders, but if we look at it among health disorders as well, addiction is common, and it's something that we need to address and find solutions for in public policy, in our personal lives, and in treatment. So I don't think there's anything in the chat, just trying to check that every now and then, because again, I encourage participation, questions, and comments, and I will try to put those in throughout if you care to throw in your 2 cents or have a question. So as we talk about the definition of addiction and what the ASAM definition, the American Society of Addiction Medicine, that within that definition, it spoke to contributing factors. This is a complex disease. It's not just one thing. I think that's why it can be confusing to people. Sometimes they want to, 1 + 1 = 2 kind of equation, and then that spells a medication I can take or this one treatment. It's not like that. But the truth is, there's a lot of behavioral and physical things out there that are complex, that are made from sort of our exposure to different things, our genes, our environment, our response to them. Well, addiction's like that as well. We do know from pretty robust genetic research, including some really sort of small waterlogged countries that have done genetic testing, that genes really do count for a lot of the risk of addiction. Genetic risk doesn't mean this is going to happen to you, but it does spell a pretty high risk. So genes account for about 40 to 60% of the risk of addiction development. And of course, the question is, how do you see if there's environment involved in there? Well, they've done some adoption studies and twin studies to try to look at and sort of untangle genetics from environment. Males more likely than females to develop a substance use disorder, and other mental health disorders that are mostly prevalent, that are very prevalent with a substance use disorder. Major depressive disorder, anxiety, schizophrenia, ADHD, and PTSD. Trauma and stress contribute to the vulnerability of a substance use disorder, as they do in other diseases, though, including mental health and biological. So in some ways, it's complex. In other ways, it mirrors the complexity of other diseases. But again, take away from this, biggest risk factor, not determining, but risk factor, is genetic. So just looking at overall harm to the person who is using the substance and to others, we come in with alcohol, number 1, which is also typically our most used substance. That varies by culture, by country, but kind of look at it worldwide, alcohol is the most used. Of course, it is in many countries legal, and there's high access, so that plays a factor. Alcohol, then heroin, tobacco, marijuana, GHB. So a piece of this is the amount of use, but also a piece of it is alcohol is the most neurotoxic of the drugs of use. This is data from 2010. This can switch, and I think that we're seeing the rise of ketamine and some other drugs out there, and especially as we're looking at some of the risk of overdose and death. So this captured a picture in 2010. Obviously, this changes, at least what I've read recently and haven't adapted to this slide, was alcohol is still number one and still considered the most neurotoxic. And then looking at disease and the cost to society of disease, we can see substance use, alcohol, and other drugs is one of the most costly. And after that, we're going to find heart disease, depression, diabetes, so on. These are the most costly diseases. And for some, this may contribute to part of the stigma, right, of substance use. Not all of it, but it in part we can see where some of that stigma may come in. Although if you look at harm to person and other people, we're going to see alcohol. When if we look at one of the most stigmatized drugs, what would y'all think that is? If anybody wants to drop it in the chat. Most stigmatized drug? Well, I don't know if I can't see the chat, I guess. So crack, meth, people have said heroin. Really, statistically, yeah, heroin is still considered one of the most stigmatized drug, followed by meth. Crack certainly has been and certainly had a heyday during when it was the most prevalent drug of use in cities, and people were associating it with crime. But heroin right now is our most stigmatized drug, and our most stigmatized method of use is going to be IV drug use, which is part of what accounts for heroin's stigma. So good job, y'all. Good job, Kristen. She gets the star. She put heroin down as the most stigmatized. Okay. And we've been over that one. So I wanted to touch on an article. It was written in 1966 by Dr. Ellen Leshner, and it's still a great article if you want to read it today. It's only a couple of pages, and it's you can Google it online. Dr. Leshner lays out the case. He was the head of the National Institute of, you're going to catch me because we're going to be changing this, but it is called National Institute of Drug Abuse. And he was a big advocate for addiction as a brain disease. And he wrote this article to, in a very short form and very easily digestible, make the case that we have the science to define addiction as a brain disease. As he says, the rubber can hit the road. And he said that the barrier to starting to get research for medication and better treatments, and okay, we have the science that it's a brain disease. Now, what do we do? Hey, we can solve this. What's the barrier? He says, this is his words, people hate addicts. Says they hate them. They're scared of them. They're scared they're going to do something to them. They're scared they're going to steal or hurt them or, decrease property values. So he says people hate addicts. He says whether you like them or not, they're a person with a disease. And if we want to do something about it, then wouldn't we want to pour our energy and attention into treating it as a disease and helping to do as we've done with other diseases, which is be able to treat and decrease the impact. That's kind of our first takeaway, is that this article was written in 1996. Dr. Leshner, he lays out the case. Here's the barrier. And where are we? We're 2025, and I'm still giving this, and stigma is still the biggest barrier, I think, to finding good and effective treatments and getting people to step up and take those treatments. Okay. And so why are we here today? Because we still have stigma, and stigma is associated with an increase in death, in poor care, in poor treatment seeking, so treatment resistance. And that's exactly what people who are afraid of addiction don't want. They want, to see some sort of end to it. And so the way we've got to do it is destigmatize. I know today I'm probably kind of preaching to the choir, but still, I know that y'all are going to take this with you today and the takeaways that we'll have at the end and spread that around us. I have seen some change over the past decade, saw a lot of attention and energy around the opioid crisis, campaigns, a lot more compassion coming out. When the COVID hit, we were seeing an increase in overdose deaths, of course, people being cut off from care, a lot of stress, a lot of isolation. But at the same time, due to COVID hospitalizations, increased fear, I was seeing an increase in stigmatization of people seeking help in a hospital for addiction. More of they're taking up a bed, they're not really sick, very, very limited resources. And so we were seeing more overdoses, and we were seeing an increase, especially in our population that are at the most risk, which is, where we see people homeless with mental health issues and substance use disorder. So it's a very deadly trio there, and they're at our most risk for being stigmatized and having very serious consequences, including mortality. I'll take a second if anybody has a question or a comment. Somebody commented in 2021, it was over 106,000. That's when the governor began to take this seriously, people losing their lives to fentanyl without knowing. Yes, I think you're right. The influx of fentanyl, and especially these accidental overdoses, we did see a lot of energy around that. I don't know if anybody else sort of saw it waning or taking a back seat when COVID came, but that's certainly something that I observed and worried me, because again, what are we going to see during the COVID crisis? We saw an increase in alcohol use and alcohol use related disorders. We saw an increase in overdose deaths. So it was like our most vulnerable time, our most stressful time, and yet we're seeing, a return to that stigma. So thank you for making that comment about fentanyl. So how did we get here? Why is there this stigma? That's a complicated question as well. But for the background, we did start to, in this country, separate medical and mental health care in the 19th century, with medical care being sort of more this legitimate care, and mental health saying, no, we're going to put these people in a separate place and keep them away from their family. And I think that contributed to some of the stigma. Of course, there have been times when drug use and alcohol use have been, we saw the Harrison Act, which created criminalizing drug use. And I'm not talking about, and then we went on to prohibition and criminalizing, alcohol. So we started to think about not only those with substance use disorders as causing issues for themselves and their family, maybe having a mental health issue, but also now it's a criminal issue. It's a criminal act, and not just selling it, but using it as well. And then this is a poster from 1971. The war on drugs was declared, and what's the enemy? Enemy number one. Is it drug sales? Is it drug trafficking? It's drug abuse. And so who's really being targeted there? The person who's using, right? It's not said, but drug abuse is the person who's using. And again, we're using that language of abuse, which we'll talk about later. So what factors influence stigma? Cause and controllability. And this is generally, this is just stigma in general. What influences stigma? Cause. Stigma goes down when we say it's not their fault. And stigma goes up when we say it is their fault. They chose it. They could have done something about it. They caused it. And then same with control. If we think to ourselves, they can't help it, we're going to see a decrease in stigma. They can help it, stigma increase. So it seems pretty obvious, but this just relates to our takeaway items later when we ask ourselves, what can we do about this? This is the education piece when we're educating about the disease. And that's why we started with some of the education pieces on the disease. So just reminding ourselves when we think about psychoed, why does it matter? And this is some of why it matters. In reducing stigma, we've got to identify addiction as a disease with that genetic influence, and that it's defined by that compulsivity using despite harmful consequences. So the same information just put into a different visual, saying the same thing, but just gives you a different view of it and kind of shows you where we see the intersection of addiction here and stigma. Okay, so we're just going to take 2 minutes. Just want you to take a moment, kind of think about your personal experience for a minute, maybe why you're here. CEUs could be one of those reasons, that's fine. But I want you to think about when stigma's touched your life. What did you notice? How did you feel? What stands out to you? You're not turning this in. No one's going to see this. I will invite a couple of people to put some comments in the chat, but this is just for you. I want you to think about just a personal experience with stigma that you've had. And then we'll take a couple of minutes to share about this, because this is kind of an academic pursuit and a call to action, but it's also personal, and everybody's been touched. So I'll give you just a minute or so to write a few things down, and then I'll check in and see who wants to share. This is going to help us develop that compassion. We think about our empathy, our compassion, something that we've been through, touched by, what would have been helpful to us, and how can we give that to others. Just reflecting on that, writing a few notes. And then wrapping up, just kind of taking that with you, what you've reflected on, and I'll invite folks to share. Okay, Sonia says that they're not able to see other chat responses, so I don't know if that's something we can change, but thank you, Sonia, for pointing that out. Anybody want to share? Okay, thank you, Shanice. And Thomas says he can see some but not all. Thank y'all. We'll work on that. Does anybody want to share just a few words of let's see, everyone. Okay. I've changed mine to everyone, and no one shared everything yet. Says Kristen, have her make sure that everybody's chat is set to everyone. Okay. Does anybody just want to drop a few things into the chat? A personal experience with stigma, how that felt, anything that stands out, whether you witnessed it or had your own kind of touch with it. Mhm. Anyone have anything? Okay. Well, I hope, okay. So thank you, Shanice. I really appreciate you sharing that. A personal experience losing somebody to addiction, and it's the most extreme loss there. Thank you. And stigma contributes to that. And we'll talk about that at the end very directly with some takeaways of what we can do. And Sonia, thank you. You see stigma on the daily. That can really wear on us, and it can make it hard to even see it as important anymore. Sonia's the pastor's wife at a recovery church. Oh, that's wonderful. I love that there's a place where people can go and feel seen and heard, and that just feel held and be able to be spiritual and not be judged. Thank you for your work, Sonia. Yeah, so sometimes seeing stigma so frequently can lead us to believe that lead us to feel pretty helpless and kind of give up. So again, we'll talk about some of the evidence-based things that combat stigma today. But I'm seeing that some of y'all are doing that already. And Amanda says, I'm in recovery, and you gave up a professional licensure in healthcare. And the stigma has been double time over the years, especially when seeking employment. I see that a lot, that employers have a lot of fear, and I think based on stigma of hiring somebody in recovery. So we're not talking about somebody who's using, but even that somebody has a background in addiction, they're still wearing that stigma. Thank you, Cheryl. Trauma specialized, who see people who utilize drugs to manage trauma. Yes, I think that is almost every person out there who's using drugs or alcohol started not to create a problem, but to solve a problem, to feel more energy, to make bad memories go away, to treat shyness or depression, for energy to be able to do, they were all seeking a solution. And one of the ones that I see a lot is to treat pain, physical and emotional pain. Thank you. Thank you so much, all of y'all who took a minute to contribute. Okay. So we talk about that from the personal, and now we go to the professional, the impact on care, stigma's impact on the provision and the seeking of care. So what we believe influences stereotypes and labels, the stigma, and then stereotypes and labels, language, stigma influences the care that people receive. Both, in all settings. I mean, oftentimes we're going to be talking about, because that's very widely studied, we're going to be talking about a medical setting, but this could be across settings. This could be service. We could say care, and that's something that can really impact people, but we can even say service, just kind of service that somebody gets. So when stigma occurs, people are less likely to seek treatment. And again, treatment in its various forms, from medication to therapy to formalized treatment programs, is what we want people to do to work on the substance use disorder. When stigma exists, they're going to be less likely to seek treatment. They're going to be less likely to stay in treatment. So this is just showing that there's some research out there. This was specifically looking at those with an alcohol use disorder. However, I think this is going to translate to different uses, drugs as well. So they were looking at receipt of services, and what they found was in the group that perceived that they had the lowest stigma, so they were not feeling as stigmatized, they were utilizing treatment the most. So there's a real direct relationship with people's perception of stigma and how often they are seeking services to treat their alcohol, in this case, alcohol use disorder, but it could be any substance. So direct relationship there. And this was a study just showing, okay, why are these patients, the first study says, hey, they're not going to go to treatment if they're perceiving stigma. Where are they perceiving that from? Well, we know culturally, but also from healthcare professionals as well. So there can be a real direct perception issue. This study looked at health personnel who work with patients with substance use problems, looked at the attitudes and the delivery system, and found that the majority of healthcare professionals were found to have negative attitudes towards patients with substance use disorders. And why? I think part of the why is because there's inadequate training in substance use cares, not among social worker therapists, but in our direct healthcare practice workers. So there's inadequate training that can really lead to not knowing what to do. And when people don't know what to do, they get really frustrated, and then they get mad and they direct it at the patient. So we see that stigmatization that then our patients are feeling, that's leading to them seeking care less. So negative attitudes towards substance use care, you might have shorter visits, you're going to have less empathy, less engagement, you're just going to have less quality care. So the impact on treatment, perceived stigma in hospitals, doctors' offices, et cetera, it discourages people from accessing health care and substance use care. And as we can see, it's going to impact all of those levels, from how much care, how long the care is, the complexity of the care, the compassion with the care. And when you ask patients oftentimes about their visits at the end, this is any patient, the part that they remember, most of the time they don't remember as much about the treatment and the skill that was part of their visit. They remember how they felt. So what's going to be the part that people really remember is if they felt stigmatized. When stigma exists, we're going to see that a lot of times people are going to hide their addiction. They're afraid of the consequences. And when you start hiding your addiction, you're afraid, You don't want to tell people. You don't want to admit you're using. You don't want to roll up your sleeves and show that you're using IV. What label comes at you when you start to hide parts of your addiction? Now you become a liar. Now you become, you know, not a useful source in your own medical record. And so you get further stigmatized. And we also see in the public sector that public policymakers a lot of times don't want to appear to condone behaviors that carry a stigma. So when stigma exists, we're going to have lots of times more rigid rules around that. People may not want to invest research dollars into solutions for substance use disorders, if there's a stigma involved. So it really has a big impact all down the line. Okay, and we've kind of talked about that. So I want to take a pause and listen to a personal account about the impact of stigma and some of what we can do. Because the next part that we're going to shift into is what can we do, right? I've been talking about substance use and stigma. Probably a lot of you are like, yes, but what can we do? So we're going to get into that. But I don't like to do anything, since I said at the beginning, I'm not a person in recovery, but I am an ally. I like to share a voice of somebody in recovery. So I want to share this from a TED Talk. And Kristen, if you don't mind sharing it, because when we tried it earlier, mine did not work. So this is going to be Michael Botticelli. Kristen, if you don't mind sharing that YouTube clip from him.
Yes.
And while you do that, we'll just, we've got it. You're fast.
All right. Cool.
"28 years ago, I was a broken man. And you probably wouldn't be able to tell that if you met me. I had a good job at a well-respected academic institution. I dressed well, of course. But my insides were rotting away. You see, I grew up in a family riddled with addiction. And as a kid, I also struggled coming to terms with my own sexuality. And even though I couldn't name it then, growing up as a gay kid just compounded my issues of isolation and insecurities. But drinking took all of that away. Like many, I drank at an early age. I continued to drink my way through college. And when I finally did come out in the early 1980s, about the only places to meet other gay people.
Hello, my name is Adam Ferrari, the Chief Executive Officer of Phoenix Energy. I look forward to you.
To socialize, to be yourself, were gay bars. And what do you do in gay bars? You drink. And I did. A lot. My story is not unique. Like millions of Americans, my disease progressed undiagnosed. It took me to people and places and things that I never would have chosen. And it wasn't until an intersection with the law gave me an opportunity to get care that I began my journey of recovery. And my journey of recovery has been filled with love and with joy, but it hasn't been without pain. Like many of you, I've lost too many friends and family to this disease. I've heard too many heartbreaking stories of people who lost loved ones to addiction. And I've also lost countless friends to HIV and AIDS. Our current opioid epidemic and the AIDS epidemic tragically have much in common. Right now, we are in the midst of one of the greatest health crises of our time. During 2014 alone, 28,000 people died of drug overdoses associated with prescription drugs and heroin. During the 1980s, scores of people were dying for HIV and AIDS. Public officials ignored it. Some wouldn't even utter the words. They didn't want treatment. And tragically, there are many parallels with our current epidemic. Some called it the gay plague. They called for quarantines. They wanted to separate the innocent victims from the rest of us. I was afraid we were losing this battle because people were blaming us for being sick. Public policy was being held hostage by stigma and fear. And also held hostage were compassion, care, research, recovery, and treatment. But we changed all that because out of the pain of those deaths saw a social and political movement. AIDS galvanized us into action, to stand up, to speak up, and to act out. And it also galvanized the LGBT movement. We knew we were in a battle for our lives because silence equaled death. But we changed and we made things happen. And right now, we have the potential to see the end of HIV and AIDS in our lifetime. These changes came in no small part by the courageous yet simple decision for people to come out to their neighbors, to their friends, to their families, and to their coworkers. Years ago, I was a volunteer for the Names Project. This was an effort started by Cleve Jones in San Francisco to show that people who died of AIDS had names and faces and families and people who loved them. I still recall unfolding the AIDS memorial quilt on the National Mall on a brilliant day in October 1988. So fast forward to 2015, the Supreme Court's decision to strike down the ban on same-sex marriage. My husband, Dave, and I walk over to the steps of the Supreme Court to celebrate that decision with so many other people. And I couldn't help but think how far we came around LGBT rights, and yet how far we needed to go around issues of addiction. When I was nominated by President Obama to be his director of drug policy, I was very open about my recovery and about the fact that I was a gay man. And at no point during my confirmation process, at least that I know of, did the fact that I was a gay man come to bear on my candidacy or my fitness to do this job. But my addiction did. At one point, a congressional staffer said that there was no way that I was going to be confirmed by the United States Senate because of my past. Despite the fact that I had been in recovery for over 20 years, and despite the fact that this job takes a little bit of knowledge around addiction. So, this is the stigma that people with substance use disorders face every single day. And I have to tell you, it's still why I'm still more comfortable coming out as a gay man than I am about a person with a history of addiction. Nearly every family in America is affected by addiction. Yet, unfortunately, too often, it's not talked about openly and honestly. It's whispered about. It's met with derision and scorn. We hear these stories time and time again on TV, online. We hear it from public officials and we hear it from family and friends. And those of us with an addiction, we hear those voices. And somehow we believe that we are less deserving of care and treatment. Today in the United States, only 1 in 9 people get care and treatment for their disorder. 1 in 9. Think about that. Generally, people with other diseases get care and treatment. If you have cancer, you get treatment. If you have diabetes, you get treatment. If you have a heart attack, you get emergency services and you get referred to care. But somehow people with addiction have to wait for treatment or often can't get it when they need it. And left untreated, addiction has significant dire consequences. And for many people, that means death or incarceration. We've been down that road before. For too long, our country felt like we could arrest our way out of this problem. But we know that we can't. Decades of scientific research has shown that this is a medical issue. that this is a chronic medical condition that people inherit and that people develop. So the Obama administration has taken a different tack on drug policy. We've developed and implemented a comprehensive plan to expand prevention services, treatment services, early intervention, and recovery support. We've pushed criminal justice reform. We've knocked down barriers to give people second chances. We see public health and public safety officials working hand in hand at the community level. We see police chiefs across the country guiding people to treatment instead of jail and incarceration. We see law enforcement, others, and other first responders reversing overdoses with naloxone to give people a second chance for care. The Affordable Care Act is the biggest expansion of substance use disorder treatment in a generation. And it also calls for the integration of treatment services within primary care. But fundamentally, all of this work is not enough unless we change the way that we view people with addiction.
I started Tai Chi at 50. Now I'm 68, and doctors ask me.
In the United States. You know, years ago when I finally understood that I had a problem and I knew that I needed help, I was too afraid to ask for it. I felt that people would think I was stupid, that I was weak-willed, that I was morally flawed. But I talk about my recovery because I want to make change. I want us to see that we need to be open and candid about who we are and what we can do. You know, I am public about my own recovery, not to be self-congratulatory. I am open about my own recovery to change public opinion, to change public policy, and to change the course of this epidemic and empower the millions of Americans who struggle with this journey to be open and candid about who they are. You know, people are more than their disease. And all of us have the opportunity to change public opinion and to change public policy. All of us know someone who has an addiction. And all of us can do our part to change people, how we view people with addiction in the United States. So when you see someone with an addiction, don't think of a drunk or a junkie or an addict or an abuser. See a person, offer them help, give them kindness and compassion. And together, we can be part of a growing movement in the United States to change how we view people with addiction. Together, we can change public policy. We can ensure that people get care when they need it, just like any other disease. We can be part of a growing, unstoppable movement to have millions of Americans enter recovery and put an end to this epidemic. Thank you very much.
Thank you. Thank you, Kristen. I appreciate that. So want to bring, you know, a voice of somebody who has been through this and in recovery in the room. And he does a great job and really speaks, I think, to the heart of the matter. So we'll get back to the presentation here. Share and slideshow. Current slide. All right. Don't know why that's, there we go. Okay. We running a little bit low on time, and of course I'm going to be respectful of everybody's time today. So thank you for listening to that. We're not going to do the discussion part. I'll just talk a little bit more about stigma and how that impacts people, and that there can be both acts of omission when stigma is involved and acts of commission. It's important to kind of remember both of those. And thank you. I'm just looking at the from Elizabeth and Caitlin. Thank you for your comments. Yeah, I think he does a great job of kind of summing up what can be helpful, and again, keeping it personal, hearing from somebody who's been through it. So thank you. Okay, so we're going to get into what can we do. And when we look at, and we'll bullet point that, but we're going to start with just the power of words. Stigma, and one of the ways that it's reflected is in language. And language influences the way we see things. So it flows both ways. You know, when we're stigmatized, we use certain language. When we hear and see certain language, we're being influenced by that, which can then cause us to see things with a certain stigma. So the reciprocal nature of this is important to remember, because then we're going to go into more detail about this later. So this is just to remind us, these things have an influence on each other. Some of the, I made this, well, somebody made this for me for a presentation a long time ago, and we asked everybody around us what they had heard, the words that they had heard currently when, let's say bedside with a person that they'd heard, in the hallways when talking about with substance use, that they'd heard from practitioners, professionals working with those who had substance use disorder. And some of the ones that we see also in a medical chart, dirty urine, alcoholic, junkie. I hear a lot or heard a lot, not in the hospital environment anymore, taken up space, taken up a bed, a lot of just negative things. And again, some of these might even be in the chart. So, we can ask ourselves, how does this feel as somebody who goes to an institution to seek help for a substance use disorder and hears this whispered or sees it in their chart? But we can also ask ourselves, if we're hearing this every day, could that have an influence on the way we see? If every time we're working in a medical clinic and somebody else is like, oh, it's another frequent flyer, here we go, waste of a bed, they're going to take up your time today. Of course that can have an impact on us and start to trickle down into the way that we see people as well. This reciprocal nature of what we think, the words we use and the words other people use, and how that influences the way we think. So words have power, and so do images. I just Googled substance use, and these are the images that come up, powerful, dirty, provocative, lots of times showing us, IV drug use being associated with it. So we just look at, what we hear, and then also we look at, you just take a Google image, and this is what you may see. Okay. So words have power, images have power. And we're going to talk a little bit about the research to show us, what can we do to kind of take ownership of the words, and how can we use words to advocate for those with substance use disorders. So we're going to look at a study, and the study was, the lead investigator was John Kelly, and he is the head of the Recovery Research Institute that I reference later. We'll look a little bit more at their work at the end of the presentation. And so he did this great study just looking at one word difference, and seeing if it made a difference in the way that people perceived this made up person. So he takes two groups of people, right, and does a study, and he just puts them in two different rooms. And in one room, the people get to hear about Mr. Williams, the substance abuser. Okay. And then they get to answer a lot of questions. Hey, do they want to see Mr. Williams go to jail? Do they like Mr. Williams? Are they afraid of Mr. Williams? And in the other room, just like I said, you just take a group of people, divide them in half. Half Mr. Williams substance abuser, half Mr. Williams has a substance use disorder. And do they want him to go to jail, and are they afraid of him? So that was the only difference, that little subtle difference, but showing the power of words. So compared to those in the substance use disorder condition, those in the substance abuser condition agreed more with the idea that that individual was at fault and that he needed to be punished. So this just shows when you look at substance abuse versus substance use disorder, more people thought that, if it was a substance use disorder, they'd say, hey, they were more likely to say, I want to offer that person treatment versus the substance abuser. They were less likely to say, if they said substance use disorder, that guy needs to be punished versus the substance abuser. Substance use disorder, Mr. Williams was less likely to be seen as a social threat, less likely to be seen at blame, more likely to be thought of as somebody who would be able to be exonerated and was able to self-regulate more. So just a very, very clear and quite nice demonstration of the power of words and how these little things can really impact the way that we think, consciously, unconsciously. So when we're talking about, we finally get to that question, what can we do about stigma and discrimination in addiction? So we started off our presentation with the first part that we can do, which is education. So I brought that, probably some of that y'all already knew, but wanted to make sure that I make that a part of this. We want to educate about the essential nature of these conditions, the prevalence, the genetic contribution. Part of what makes them defined as addiction is the compulsive nature. So education is essential. Number two, putting a face and a voice on recovery, getting to know somebody in recovery, lifting up our recovery friends in the community. Today, I did that through introducing, the speaker, somebody in recovery. And then finally, it's what we're getting to, changing our language and terminology. Words matter. Words have power. Words impact the way we think, and the words we use have an influence on other people. So we want to change our language and terminology to be consistent with the nature of the condition and the policies that we wish to implement to address it, and to be consistent with the current clinical language, right? So when we did the education at the beginning, old language, substance abuser, substance dependent. Current language, so to be clinically correct when we're in our professional role, would be a person with a substance use disorder. What our clients, what our friends, what the people who have the disease of addiction decide to, do or use is their own. But we're talking about, as clinicians, as people in the field, the way that the language that we use. Okay, so little bit, we've talked about this already, but we're going to switch to clinical language and documentation. As we've said, it influences the way that we think about things. It also influences our patients. When we're saying, hey, have you been abusing cocaine lately because you got a dirty urine? That's going to be a very different conversation that comes across to our patient if we say, I noticed that your drug screen was positive for cocaine. Is a substance use disorder something that you're dealing with? We have resources. Different conversation, much less stigmatizing. When our colleagues hear us modeling clinically correct language, both in what we say to the patient, what we say to our colleagues, And what we say in the chart, documentation can be a way that we can advocate for our patients. As I said earlier, when we experience, when we see, when there's a lot of stigma around, we can feel kind of hopeless, and that question can come up time and time again. What can I do? And is there any point to doing anything? This is something we can do, changing our language, being aware of our language, that can be empowering for us, empowering for our patients, and can really have an influence on other people as well, family and colleagues. So there's tons of these out there. The Recovery Research Institute has these. There's posters that are free. I think the Addiction Prevention Coalition has these, or did at one time. I got a ton of them. They can be put up in offices, but lots of different examples of these recommended language. So when we, and again, the person who has a substance use disorders in recovery may say different things, but we're talking about clinicians and those who are allies. And so we want to stay away from words that imply good or bad. So clean and dirty, we want to stay away from. We would say a person in long-term recovery instead of clean. Drug abuser, one of the reasons that people have gotten away from abuser and abusing and abuse is because of the connotation and the connection that a lot of people make consciously or unconsciously with physical abuse, child abuse. And so there is such a negative connotation there that so sort of overshadows sometimes the facts of that somebody's using drugs, that it's a disease. So really trying to shift to a substance use disorder. This doesn't mean somebody using drug abuser is a bad person. Again, we're looking at the history. That used to be the term, right? And I see it daily in current medical documentation. So it takes a while. It takes a while for us to catch up, but the current correct clinical use and what we have found produces less stigma for the person, and the people hearing it is a person with a substance use disorder. Same with alcoholic. People still use that in 12-step communities, recovery communities, that's fine. But if we're, in our clinical world, if we're not the person with in recovery, then we want to say alcohol use disorder. Dirty urine, or same thing, clean, dirty, those are very black and white, and they're not really specific terms either. If I'm writing in the chart or saying dirty urine, that doesn't give me as much information as, urine was positive for blah, blah, blah. So it's both clinically correct, it gives us more information, and it's much less stigmatizing. My one of the ones that I hear the most is a frequent flyer in some clinics, and it was I'm gonna forget her name, but she was a person in long-term recovery, and she was also worked in Georgia, like a coalition for recovery, and her term was friendly face. And when I worked at UAB Hospital, and part of my team was a consult team, and the consult team would go housewide all over the hospital. If any healthcare provider put in an order for us to meet bedside with somebody who had or was suspected to have a substance use disorder, and they wanted that to be addressed as part of their medical care, we started all using that friendly face term and would even try to, as a way to kind of model one of the ways it could be some excitement. Oh, okay, I know that person, friendly face. We have some ideas for them, sort of like trying to model that when somebody comes more frequently and we have some knowledge about that person, that it actually helps us with their care. So that may come across as a little Pollyanna, but it was something important to me and my team to model that and to really show people the way it can be when we're working with somebody who has a chronic medical illness. The truth is we may see them for care more than one touch. It may take more than one touch if we're dealing with a chronic medical illness. So I've been talking for a minute. Do I need to check in? Anybody have a comment or anything you want to ask? And just wait 1 second if you want to put it in the chat. If not, we're good to go. Okay, so myself and my husband are people in long-term recovery, and after 10 years of separating herself from her dad, my husband in recovery now since 2017. I'm glad you shared that, that they're now reuniting. Thank you for putting that. Thank you for putting that and about your own long-term recovery. And one of the things that I see and that I'm glad now is in that definition of addiction as a disease that I shared with you at the beginning. They now include that recovery is possible, that people do recover just as they do from other chronic illnesses. So thank you for saying that, Sonia. All right, so I want to give an example, a clinical example from a chart. This is not a real chart. This is not a real person. This is totally made up by me. However, it's a compilation using language that I see and was seeing absolutely every day when I was working on consults. So, you know, we've taken it from looking at that research study where they looked at abuser versus somebody with a substance use disorder. We've looked at Recovery Research Institute's do's and don'ts, and here's a chart, do and don't. Here's how we can use our documentation as advocacy. And I want you to see how when we change it, it doesn't, if you're looking at like even how many words, because I don't know about you, but like, you know, we're all trying to chart very quickly. It doesn't take that many words. And what I think is part of what can be stigmatizing to those with substance use disorders and why people get so mad at them is because they don't know what to do. They want to help. So the more that we can kind of think in solution-based terms and offer that to other people, I think it helps reduce the stigma as well. Like I said, when we were like my team, you know, when people would let us know, hey, Mr. So-and-so is back again, we'd say, great, friendly face. We know him and we have some resources that we can draw on. That really lets people know we know how to handle this, and that reduces fear and that reduces stigma. So look at the difference. We have Mr. Smith. I swear I've seen this in charts a ton. He's a long-term drug abuser and he frequents the ER. He returns today complaining of being in withdrawals, but is in no obvious distress. He's clearly drug seeking as he's repeatedly asking for Suboxone, which is a medication that's prescribed for substance opiate use disorder. He always denies opportunities for treatment. Plan to discharge with standard comfort measures recommended. So if we see here and if we read this, what's our reaction going to be? I'm not going to spend too much time with this guy. He's always here. He's complaining. He's drug seeking. Hey, he never takes treatment when they offer it. I'm just going to get him out of here, as they say, discharge, standard comfort measures, which means some Tylenol and a cup of water. Versus Mr. Smith presents, so we're using that clinical language, with an opiate use disorder, I should have put a comma, severe. he's reporting withdrawal symptoms. His state of change related to treatment is pre-contemplation, so I am noting that he may not be interested at this time. However, I'm also noting, using the stages of change model, that could change. So his treatment, his stage of change related to treatment is pre-contemplation. So we plan to page for peer support to work on motivation. So what do we do if somebody's in an early stage of change related to their substance use disorder? We bring in motivational interviewing that accepts where they are, sees if there's motivation for change. And then we can also bring in addiction medicine to discuss medication for opiate use disorder. So instead of the drug seeking and writing off, seeking Suboxone, seeing that as a medication for opiate use disorder, and that we would bring in an addiction consult. So we leave with a plan and something that we can do with the person there, instead of the only thing that we can do is get rid of them. We normalize that a stage of change in substance use is not ready to change yet, pre-contemplation. So doesn't take any longer to write or assess. And here we've advocated for the patient, and we've advocated for some more specific measures that we can do. And even sort of hinted at the future, that this person may return, and we know also competently what to do in this case. Much less stigmatizing, not more work. And so if I'm reading this as, say, a resident, Mr. Smith number 1, oh, I'm scared. I don't want to see him, and I'm going to kick him out real fast. Mr. Smith number 2, I got it. I know what to do. And if I see him again, I already have that plan in mind. So, any questions there? Any comments? I'll check the chat real quick. How do I effectively love her while standing up to stigma in this process? Yeah, that's what a good question. So hard, because oftentimes we do love people who might use stigmatizing language and might, believe some of those stereotypes still. And I think that, as we started this presentation today with compassion, how does somebody develop stigma? Probably based on what they've seen and heard. We can bring some self-compassion to ourselves, not knowing exactly what to do. Bring compassion to them is probably stemmed from something. We can model correct language and compassion. That really opens the door for somebody to be able to change. When we don't shame them, we can say, hey, I don't like what you're saying, but I understand where that came from. And then we model clinically correct language as well. So great question. I'm glad you asked that. How are we dealing with this? I want to, and if there's any more, y'all put it in the chat. I am here. I'm ready to talk and listen. I want to switch to one of the most serious risks related to stigma and working with this population. We've touched on that overdose can be a consequence, but I want to just touch on suicide risk with this population and how that relates sort of broadly to this population as well, but also what happens with stigma. And what we can do about it, what we can do if somebody is having some suicidal ideation. So I just wanted to say, we're going to talk about that. I'm not going to go into detail about anybody who's died by suicide, but we'll be talking about risk and some of the risk factors related to stigma that contribute. So take care of yourselves in any way you need to. Put something in the chat if you need that to be addressed. So this model, I believe that stigma, somebody who's perceiving stigma, it can increase their vulnerability, and that includes in the realm of suicidal ideation. This slide that you're seeing, this image that you're seeing, is a model by Dr. Joyner, which is called the interpersonal model of suicide. And it's a newer model that tries to look at the drivers for suicidal ideation. And, of course, then we get into the what do we do about it? So some of the drivers for suicidal ideation, two of the biggest ones, if we look at the top two circles, a feeling of burdensomeness. I am a burden. And so we know that those with substance use disorder often feel this way and perceive that others see them this way. Remember that language, the power of words, waste of space, waste of air, waste of a bed, taking up a bed, dirty. That can contribute to somebody feeling like a burden on society. The other one is feeling of isolation. They also refer to it in the literature as thwarted belonging. I'm alone. I don't belong. I'm an outsider. So again, we're going to see a lot more risk for that with those with a substance use disorder that is stigmatized, the feeling that there's no hope for me, I'm a burden, and which may be literally true. There may be thwarted belonging, that they're rejected due to the stigma and some of their own behavior and some of the consequences. So the feeling of isolation, that feeling of burdensomeness, and where that intersects with capability for suicide, meaning lots of people may feel like a burden, feel that isolation, they don't belong, when that's combined with somebody who has the capability for suicide, meaning the access to lethal means, the access. Most folks with substance use disorder may have that access in their hands, an overdose attempt. They may have that access. They may have the capacity. What also it increases is if somebody has had an experience like almost completing before. So who is that going to speak to? Are folks who may have had a history of overdose. They know that there's the capacity there. They understand what it might take actually to complete suicide by overdose. So feeling like a burden, feeling alone, there may be that desire for suicide. When we add in the capability, then we're really working with a high-risk population. When we also look at the literature, anybody who's had a history of a suicide attempt, a mental health or substance use issue, is at high risk. So these are folks that I am advocating that we really want to intervene, ask the question, because these are very folks who may be at very high risk. And remember that the majority of folks who have a suicide attempt, it is typically they've not thought about that for a long time. It can be something impulsive. What creates impulsivity lots of times in people? The use of a substance. So a lot of times when we're looking back at those who've completed suicide, substance use may have been something that increased that impulsive capability. So something that I want us to be aware of. What do we do about that? If we acknowledge that this stigma enhances the vulnerability of an already vulnerable population, it enhances that thought of, I don't belong and I'm a burden. We want to ask. We want to ask. A lot of people are afraid to ask about suicide. However, research shows that asking does not increase desire. There's the Columbia rating scale out there that is a great scale specifically designed to look at suicide risk. It's a free instrument, evidence-based, and can be accessed, just by Googling the Columbia screening form. So that's something that I really encourage is us to ask and to check in with these vulnerable people. To certainly validate that somebody feeling that way can make sense. And given, the stigma, what they're going through, and that there's some things we can do to help. There's 2 safety plans out there that are evidence-based and free. One is CALM, counseling about lethal means. It's a free training. It's a 2-hour training. You can Google that. It's really well done and very broken down into a simple but not condescending way. So I really encourage folks to consider doing the CALM free training. And then the Stanley Brown Safety Plan is a free evidence-based individual planning tool that helps the person make a safety plan with their practitioner. And then in the bigger picture, if we're really addressing the feelings of isolation and burdensomeness, then we're working with somebody on the ways to connect to other people, the ways to contribute over time, ways that their experience might mean that they have something special to give from their lived experience, especially if we're working with some of our folks who are in recovery. What has their recovery given them that might help them connect to others? What has their experience been? This is, where we can also come to our recovery community to help connect. I've mentioned that peers and peer support were a big part of the team that I worked with at the hospital. They can come in sometimes and really connect with somebody on this feeling of isolation and some of the products of stigma, or somebody, sometimes a clinician may not be able to do that as well. So, we definitely want to ask when we're dealing with our high-risk population and our stigmatized folks or some of our highest risk populations, validate their feelings, safety plan, talking about access to lethal means and getting a safety plan that's client specific on board. So thank you for letting me drop that in. It's just, serious. And when we're working with a high risk population like this, we always want to address that. Let's see. I'm just looking at the chat. I'm going to go back to that for just a second. I believe this is perceived in very similar manners, be it adolescent or adults with stigma. Yes, I agree. Compassion is a good word for me now. Thank you. Any questions or comments on this stigma, just increasing vulnerability for suicidal ideation and risk? Okay. So we've talked about what we can do, the power of language. We've talked about education. We've talked about compassion. We've talked about putting a personal face on recovery through utilization of peers through, meeting and encouraging those who are in recovery if they feel comfortable to share and acknowledge their experience. And last, I want to encourage folks to, when we think about stigma, to think about stigma as the issue, not the people. So it was a while back, as part of hospital education, we had a program called Addiction Scholar, which was an education and project-based program in the hospital that brought people from different fields to educate for over a year and to engage in a quality improvement project around bringing education, knowledge, and lowering stigma about addiction in the hospital through, educating people from different professions. And we did some stigma work as part of that, and really, in a very direct way, confronted people about some of their biases. And one of the participants said, you're kind of shaming people for having those biases. And it really hit me. And that's a good way to shut people down. And so that is not something that I want to do anymore. I want to direct education efforts, change efforts at the stigma, not the people who are exercising the stigma, because oftentimes that person who has the erroneous beliefs, they come from a place. So we want to push on, we want to reduce stigma through our education efforts, through correct language, but not through sort of confronting individual people or shaming them. And I found these sort of nice efforts from the Recovery Research Institute, which encourages people to write and post to stigma itself, a message to stigma. And it's called Dear Stigma. And I want to look at two, and then I want to give y'all just a minute if you want to drop it in the chat to come up with your own. So our takeaways and to do, we educate that addiction is a disease, but we stress it's treatable and most recover. Recognize the behavioral components to the disease. Compulsive behavior is part of the diagnosis. We make it personal. We talked about that, including peers, changing our language, and challenging the stigma and the system instead of individuals. And here's the campaign I was talking about, Recovery Research Institute, Dear Stigma. Dear Stigma, abuse is a terribly stigmatizing word when it comes to this disease. How can we classify it as a disease and then call it abuse? Dear Stigma, as a recovering addict, clean and sober for 15 years, and not once did I refer to myself as a drug abuser. It's a horrible, debilitating disease, not an abuse. It ruins the lives of the addict and those around them. It's time we change our attitudes towards treatment of and labels for drug addicts and addiction. Stop adding to this disease by adding shame with the stigmatizing word abuse and call it what it is, addiction. So we end with some of those words from somebody in recovery aimed at addiction, aimed at changing through language and advocacy. And if any of you want to drop in the chat your own Dear Stigma, please feel free to do so, and we'll read those out. And I am also here for questions, for comments, to be here to discuss or, respond to anything that y'all have from this presentation today. And again, if you want to put in your own Dear Stigma comment, feel free. Okay, get a copy of the material. Let me check about that. I think if I can make it a PDF, then yes, I will. And Thank you, Sonia, for saying that. Correct language and compassion. Yes. Oh, a video recording, yes, of today's webinar. They did video it, and I think they do make that available. Thank you. And Kristen is asking if you'll please do the brief survey. We want you to do this so you get your CEUs for today. And I want to thank everybody for coming. And Sonia's saying she still has shame when she thinks about that, when she says those words to herself, how I abused myself. And said she's going to make a conscious effort to apply this information in the self-compassion as well. I'm so glad. And if we bring that voice of compassion to yourself and maybe even, use the words, I get sad when I have memories of what I've experienced. It may lessen the shame. You say that versus the how I abused myself. But Sonia, that's really common and very vulnerable of you to share. Thank you. Anybody else? I'm just going to put it on, somebody was saying it's helpful to have those the takeaways. Where did we have those? Well, oh, we'll find those and see if we can get this shared with folks. Anybody else? Any comments, any questions? If y'all are taking your time to fill out the survey, I'm glad, because we want you to get CEUs. They're so important. And thank you for choosing these CEUs. Really happy to see so many people here today.